Good evening, everyone. Thank you all for joining this webinar and spending your Thursday evening with me. And I'm sure there's a lot of things that you could be doing right now, such as watching Thursday Night Football. But I do appreciate that you're spending some time out of your busy lives to learn about what I like to call an old friend, the role of limbal relaxing incisions in modern cataract surgery practice. So I'll try to keep my comments relatively short and try to leave adequate time for some Q&A. I believe there's a function there where you can submit questions via the chat feature, as well as I'm not sure if it's open for everyone to chime in, but we'll certainly try to have some time for that at the end. So without further ado, let's go ahead and just kind of jump in here. Here we go. All right, so I don't have any financial interest in any of the products, drugs, devices. I am receiving an honorarium to give this talk. I have some unrelated disclosures that are listed there. Okay, so let's kind of talk a little bit about corneal or keratometric astigmatism, and then we'll kind of segue that into limbal relaxing incisions themselves. So a little bit of review here. So corneal or keratometric astigmatism, there's different types of astigmatism. There's refractive versus ocular, regular versus irregular, simple versus compound. But for the purposes of our discussion tonight, we'll kind of limit it to corneal versus lenticular. We'll assume that all of the refractive astigmatism can be split into corneal versus lenticular astigmatism. When we perform cataract surgery and we remove the lens does technically have, everybody has some lenticular astigmatism. And that phakic lenticular astigmatism was one of three things. It was so minimal that it was not affecting the corneal astigmatism at all. It was a lot, but it was actually amplifying the corneal astigmatism, which is good because we're removing the lens and therefore we don't have to do as much astigmatism correction as we thought we would need to. Or in many cases, it was neutralizing the corneal astigmatism, and by removing the lens, we have to now figure out a way to neutralize or at least reduce the corneal astigmatism to deliver the best refractive outcome to our patients. And obviously, toric IOLs are an option to do that. So when we remove the cataract and we place a monofocal IOL, we're basically removing the lenticular astigmatism. So the question, especially in modern cataract surgical practice, that we have to ask ourselves is, how are we going to address the pseudophakic corneal astigmatism? In other words, the amount of astigmatism that will remain after cataract surgery if we simply placed a monofocal IOL. Let's kind of use an example. We've got two identical twins that need surgery. Both of them have significant refractive astigmatism. So let's say they're both wearing the prescription of a -5 + 3 × 90. The first twin, biometry measurements are 44 by 47. So there's 3 diopters of keratometric astigmatism at 90. And the second twin has very minimal astigmatism at 90 degrees. So when we are going to do surgery in twin A, we certainly have to discuss the astigmatism correction options for this patient. Now, this is 3 diopters of astigmatism. A toric IOL will probably be the best option for this patient, especially if finances will allow. But for twin B, this patient will do very likely well in a non-toric IOL, and actually will do probably worse with astigmatism correction with a toric IOL or even with a limbal relaxing incision. So we have to ensure that when we are going to address the corneal astigmatism, we have to make sure that it is regular. So what is regular astigmatism? It has to basically be here, like we see in panel B here, that it has to basically be the same orientation and the same amount, both in the steep and flat meridians. In other words, it has to be a symmetrical football. Right, that's how we want to imagine what regular astigmatism is. It's a symmetrical football, and it can be corrected with glasses and soft contact lenses. Irregular astigmatism is basically kind of, imagine a football where someone's been sitting on one end of the football. So it's kind of an irregular shape. It's variable in both meridians. The principal meridians may not be 90 degrees away from each other, and it's going to cause irregular Myers on keratoscopy or placido disc topography. These corneas cannot be fully corrected with glasses or soft contact lenses. Almost by definition, they can only be corrected with hard contact lenses or RGP contact lenses. Biometry doesn't fully tell the story. When we get biometry measurements at the time of cataract surgery, the biometry device will give the astigmatism measurement. It'll say this patient has 1 diopters or 2 diopters or whatever it might be. And even whether you're using with K values or TK, there's no kind of red flag that, oh my gosh, this patient has irregular corneal astigmatism. So really we need corneal topography, and certainly more and more surgeons are routinely getting corneal topography, but we know that corneal topography, unless there's a medically indicated need for getting it, CMS and Medicare won't reimburse for that. So that's something you either have to eat out of pocket or find a reason to actually perform corneal topography. So here we have a patient here with regular astigmatism. Even though this patient has maybe possibly some early form fruus keratoconus, we can see that the axis, we can actually draw a straight line between the steep here, the red line here, and the flat meridians over here. So this would be a patient, even though this patient was form fruus keratoconus, where something like a toric IOL may be reasonable. But here we have a patient in the bottom panel here where we can see that it doesn't pass the so-called pencil test. You can't draw a pencil in a straight line from the top of the cornea to the bottom of the cornea. Here we have one meridian going like this, and then the other meridian going like this. So it's kind of like a broken straw or a tilted straw. So this is obviously definitely moderate keratoconus. And this patient will not do well with a toric IOL and will not do well with a limbal relaxing incision because this patient has irregular corneal astigmatism. So why do we need to care about this? Because if we have ascertained that a patient has regular corneal astigmatism before doing cataract surgery, and if we come up with a game plan to correct that corneal astigmatism, we can deliver the patient both better objective and subjective best corrected visual acuity and uncorrected visual acuity after cataract surgery and intraocular lens placement. So let's kind of review the types of keratometric astigmatism. There's with the rule, against the rule, and oblique. So with the rule would be from 70 to 110, against the rule would be from 20 to 200, and oblique would be sort of in between. Typically with the rule and against the rule are going to be better tolerated. If we know that we all, when we're younger, we have more with the rule astigmatism and we gain some against the rule astigmatism because of posterior corneal changes with aging that happen. But by and large, with the rule and against the rule are going to be much better tolerated than oblique astigmatism. So again, this is just a review. I'm sure most of you know this, but it always helps to kind of understand what we're talking about. So here, if we look at the green triangles here, this is the with the rule astigmatism. So that's 20 degrees on either side of 90 or 270, however we want to call that. Against the rule astigmatism is going to be 20 degrees on either side of 0 and 180. And oblique astigmatism is going to be basically the pie slices in between. So this is going to be against the rule, oblique, and with the rule. And why is this important is because most of us now, especially in modern cataract surgery, sit temporally and we make our incisions, with over here for the left eye and over here for the right eye. There's still a number of good surgeons that still sit superiorly, and there's nothing wrong with that. But that helps us to understand that if we have astigmatism in a certain meridian and we're operating actually 90 degrees away, even though we're using smaller and smaller blades now compared to the days of 3 millimeter and 3.5 millimeter wounds, most people are using around 2 millimeters or 2.2 wounds, that the astigmatism we're creating with our incision, and conversely, the amount of astigmatism we're able to correct with the incision is very minimal. And therefore, we have to make sure we are brainstorming ways to correct the astigmatism 90 degrees away with some of the options that we have that we're going to talk about in just a little bit. Keratometric astigmatism is quite prevalent. So up to 50% of our patients can have significant corneal astigmatism, and about 10% of patients have more than 2 diopters. Multiple papers have shown that even up to 0.75 diopters of corneal astigmatism can cause the need for glasses and can make basically your patients unhappy by causing problems such as glare and halos and meridial magnification. Correcting corneal astigmatism is important for all IOLs. So obviously a monofocal IOL, we're not able to correct the astigmatism with the monofocal IOL. And so therefore we have to think about, options such as limbal relaxing incisions, or perhaps if a patient wants what's known as bioptics, where you place the IOL and later on then do laser refractive surgery. But then of course the finances and the expenses associated with that can be quite significant. Presbyopia correcting lenses is a huge area where correcting astigmatism is going to be very important, and especially we know that these lenses many of these lenses do come in toric versions, and we don't have time to go through all of the presbyopia correcting lenses that are available in the United States, but certainly correcting the astigmatism at the time of placing these lenses is going to be very important to give good outcomes for these patients. Now, one of the areas where the limbal relaxing incision can be very useful, and we'll talk about this in some of the next slides, would be if, let's say, you have a patient who's got a presbyopia correcting, who wants a presbyopia correcting lens, and they've got like 0.9 diopters or maybe 1.1 diopters of astigmatism. So not enough for a toric, but also not enough where you feel comfortable, especially if it's against the rule, leaving them with that amount of astigmatism. And that would be a great example of a patient where using a limbal relaxing incision may deliver much better uncorrected visual acuity. And certainly now with the recent advent of the Eyhance, which is really not an extended depth of focus lens, I kind of call it a monofocal plus. It's sort of an in-between lens. But the Eyhance is a very useful lens for a lot of situations where patients kind of want some presbyopia correction, but for either financial reasons or maybe because there's other things that are going on, they may not be the best candidate. So for example, post-laser vision correction patients, or patients, we do in my practice a lot of triple DMEC, and so I don't feel comfortable putting in a like a multifocal lens or a extended depth of focus lens in those patients, but putting in an Eyhance certainly, and we've been tracking those outcomes for both distance and near and intermediate visual acuities at all three distances, but correcting the astigmatism with the little limbal relaxing incisions can be very useful and very helpful in those types of situations when using that lens in particular. And sometimes some surgeons may feel that, hey, I'm not really getting this increased near and intermediate vision with this lens. And if we're not correcting all of the astigmatism, especially if there's against the rule astigmatism, then we're kind of, it's like buying a Porsche, but only driving like 30, 40 miles per hour, really not unlocking the full features of that device there. So there's a lot of keratometric astigmatism that is out there. Okay, so what are our options for correcting corneal astigmatism? Well, the top two aren't really done anymore. Operating on the steep meridian, like I said, the incisions that we use don't really correct a whole lot. Especially with smaller and smaller incisions, they don't really correct a whole lot of astigmatism. Some people have talked about doing an opposite clear corneal incision. I'm not really a fan of making any additional wounds in the eye if we don't have to, so I won't really talk too much about that. Obviously, toric IOLs, we know that there's enough of a track record with these lenses. They're very accurate, longer lasting. Obviously, the cons would be the amount of money that patients have to pay out of pocket. Some patients simply can't afford the toric lens. Sometimes these lenses may rotate, or we may under or overcorrect, especially if we don't account for the PCA, or the posterior corneal astigmatism. We talked a little bit about laser vision correction, bioptics, again, the finances associated with that. I do want to talk about a topic which a lot of people have, certainly at congresses and meetings have brought up, which is about doing femtosecond laser assisted arcuate keratotomies, femtosecond laser AKs. And the question that I would say is, where is the evidence? And when femto first came out, everyone was all excited about, oh my gosh, we can use these lasers to make incisions to correct the astigmatism. But if we look at the literature, really, I mean, how effective are there? A paper that was in JCRS 2018 showed that when you head-to-head comparison with femto and manual LRIs, you really got about a quarter diopter more with the femto compared to a manual LRI. So the question is really, we're charging patients $1,500 for a quarter diopter. What's the clinical significance of that? In a recent AJO paper last year, they saw in 1 year, there was a reduction from about 1.6 to 0.66 diopters. So really about a 60% correction was really achieved with femto. So really, we're only correcting about 60% of the astigmatism that we really want to do. People worry about what if you perforate the cornea with limbal relaxing incisions? Well, certainly that's been reported with femto AKs as well too. And you can see the references that are there. But the other recently, there was a big comparison, large number of patients with manual LRIs. This is a meta-analysis. Patients who had manual LRIs versus femto LRIs, and you can see the numbers there. I won't bore you with all of those numbers, but basically it's very underwhelming. And the authors basically concluded, since visual and refractive outcomes appear to be similar in both cases, the cost-benefit analysis is quite controversial. In other words, if you look at the correction index of both of the manual LRIs and the femtosecond, it's not really a whole lot of difference. That's not statistically, there's no significance there. In other words, telling us that manual LRIs, as much as people think that they're old school, these were done back in the 1990s and early 2000s, and now we got all these cool toys and stuff, maybe it's time to revisit an old friend. And so maybe we got to realize that there was so much fanfare and hype for femtosecond AKs, when really the good old LRIs have economy, there's efficiency, there's effectivity, and there's less exposure in terms of problems caused by irregular astigmatism and perforations that have been reported quite extensively in the literature with femtosecond laser AKs as well. So what is our old friend limbal relaxing incisions? These are partial thickness incisions that are made in the corneal periphery for the treatment and reduction of corneal astigmatism. They utilize the principle of coupling. In other words, if we make an incision in one meridian, it's going to flatten that meridian, but it's going to steepen the meridian 90 degrees away. So it's really a 1-to-1 ratio. In other words, in terms of the spherical equivalent of the average astigmatism. So for example, if we have pre-op Ks of 44 and 46, and we made a perfect limbal relaxing incision that didn't change afterwards, that would mean that the patient had a cornea of 45 diopters in all of the meridians, and that would be the ideal scenario. We know that doesn't happen, but I just point that example of that's what the perfect limbal relaxing incision would do. So it's important that if we are going to venture into the world of limbal relaxing incisions, the preoperative exam isn't that much different than what we would do for regular cataract surgery. We certainly want to make sure we do a good exam, look at the peripheral cornea, make sure there's not things like Salzmann's nodules or thinning from PUK or Terrien's marginal degeneration. So basically make sure the peripheral cornea is healthy, make sure we get keratometry and topography measurements. Again, we said topography is going to be very important to make sure that there's no irregular astigmatism. And if possible, again, I have to confess, I don't do this routinely, but you can get pachymetry at the planned incision sites. And that way, if you have an adjustable blade, you can set it exactly to 80-90% depth. By and large, though, if you get a 600 micron blade for pretty much most corneas, that would be safe and effective. So I wanted to kind of come up with a catchy, acronym or a catchy little mnemonic that you can remember. So I'm going to call it the 5 S reasons for why we should do LRIs. And these are the 5 reasons: that they're simple to perform, they save time, right? You don't have to go to the femtosecond laser. Those of you who've done femtosecond laser cataract surgery, you know that it takes much more time to do these cases than to do your routine manual cases for most surgeons. They're very successful for correcting astigmatism, and that leads to a satisfied patient. They're very safe, so there's safety for the patient. And finally, it can provide supplementary income. And certainly, I believe Pat Reichert will talk a little bit more about that towards the end. But in these days, when there's decreasing reimbursements for cataract surgery, if there's a way that we can supplement income in a way that is safe to patient and provide something that they can actually feel that you've given them, certainly that's something to consider as well. So how do I get started with LRIs? Well, again, they're very simple to perform. There's plenty of published nomograms that are available online. I'll show some of those on the next slide. There's also a website which is called LRIcalculator.com, and this is very similar to toric IOL calculators that are familiar to most surgeons. You can go there and basically put in information such as what are the preoperative Ks, where you're going to make your incision, et cetera, and then you hit calculate, and I'll actually tell you where to make your LRI incisions, and it actually gives you a nice little printout that you can bring with you to the operating room, just like many surgeons do for toric IOLs. These are various nomograms. Again, don't want to bore you with all of this, but there's the Napa nomogram, which is by Skip Nickerman here, that shows here, and this can kind of get pretty complex based on the patient age and the amount of diopters of cylinder that's there. The Gill's nomogram is a little bit easier to kind of follow. This is the Baylor nomogram down here. Again, also a little bit easier to follow as well too. Kind of simplifies, but by and large, you can see that there are these nomograms that are available that you can kind of keep. Many surgeons have this available in the OR in their surgical planning booklet or something like that that they can use for kind of quick reference, because it is a little bit difficult to know all of these numbers exactly. Now, the other surgeons, especially when we have our residents or fellows and trainees perform limbal relaxing incisions, I tell them to use this website because it makes them, first of all, makes them familiar with some of the resources that are out there, but it also kind of gives them a printout page that they can bring with them to the operating room. They can stick up on the wall or right next to the microscope, and that way there's no what's the word I'm looking for? There's no doubt or any, lack of information as to what type of incision that they should make. So here it kind of shows for the right eye where you're going to make your incision, where you should, here's the main incision here in green, the limbal relaxing incision there is shown in yellow, and it kind of shows how much degrees to make based on the amount of astigmatism that is there. This is what I just call the Riaz nomogram. It's not validated by anything or anyone or by any stretch of the imagination, but it's a kind of a quick and fast, what I call the 40, 50, 60, 70, 80, based on 1, 2, 3 diopters of astigmatism. And it's very simple because for width the rule, assuming that you're going to make a temporal clear corneal incision, it's 40 degrees times 2 centered at the steep meridian. If it's against the rule, it's 50 degrees times 1. So you can kind of use this quickly on the fly if needed. So for example, you have a patient with 1 diopter at 90 and you sit temporally, so you're going to make your incision at 0 degrees for the left eye, 180 for the right eye. You can realize that, okay, 1 diopter at 90, I know I have to make 40-degree incisions from 70 to 110 times 2, and that will kind of give me the correction that I need. Same thing if there's 1 diopter at 180 and you're sitting in the left eye, you can make your clear corneal incision at 0 degrees, and you can make your LRI 50 degrees centered at 180, so that'd be 155 to 205 times 1. If there's astigmatism in between, you can simply add 5 degrees. So if there's a example of a diopter and a half of astigmatism, you can make them 45 degrees times 2. So again, this is just a 40, 50, 60, 70, 80 that you can just almost draw out and just remind yourself how to use. And it's basically a summary of all of these that I didn't come up with my own nomogram. I just basically looked at all these. I'm like, okay, this is kind of a average summary. And so this is what I give to our residents and fellows to use here. So let's move on. So how do I perform LRIs? Well, and so what are the potential times to perform LRIs? The first one would be, and that's what I would recommend, it's when I do my LRIs, is really before any incision, especially for cataract surgery. So really even before your paracentesis or anything like that, the eye is at physiological pressure. So you can simply mark using an inked Sinskey hook, and you can see the equipment that's needed, and just make your LRI incision and move on with the rest of your surgery. Some surgeons like to actually put the viscoelastic in. They feel like it really pressurizes the eye appropriately, so basically before the rhexis. And others will do it after the placement of the IOL. Some do at the end of the case. Again, it really doesn't matter. It just really when you're most comfortable making the LRI. The equipment that's needed is very simple, and I know that the folks at Precision Lens are also have made it easy to have sort of the disposable kits for surgeons who may not do these regularly, maybe just want to do them occasionally, but really just need some sort of a gauge marker, like a Mendez gauge, and then an inked Sinskey hook for starting and stopping points. You can mark preoperatively in the sitting position if desired. I certainly do that for toric IOLs, no doubt. But sometimes with these, since it's not really an exact science, you can just use the limbal landmarks, like a limbal girdle evoked, for example, to figure out where's the 0 and 180 and kind of work your way from there. As far as the LRI blades, there's a lot of options. Certainly, my preference would be a reusable blade, in other words, a diamond blade, and that's what we're fortunate enough to have at our facilities. But I certainly do sympathize and understand that the finances with diamond blades is it's not an easy pill to swallow. These are usually several $1,000s each. Some surgeons may operate in facilities where there's other cases besides eyes, such as ortho or gynae, and you don't want your diamond blade to be tossed in there with, I don't know, a bone saw or whatever the heck ortho does, and the blade to kind of get damaged. So for that reason, there are disposable blades that are available. And again, I think some of the precision lens folks will talk about some of the options that are there. And these are really good options for surgeons who maybe don't perform these a whole lot, or maybe operate in a facility like a hospital-based ASC, or some people actually do just like the disposable blades more than the diamond blades. But anyway, basically you can use any of these. So all of these blades are kind of these fixed depth or adjustable depth that are set for 500 to 600 microns. Again, you can also, if you wanted to be really scientific about it, measure the pachymetry in the peripheral cornea. Let's say it tells you it's 670, and then you can basically do 80% or 90% of that and kind of go from there. So you can use an adjustable depth blade to do that. But by and large, for example, in my practice, I pretty much use a 600 micron blade, and that pretty much keeps us out of trouble and is pretty effective, compared to having to measure and adjust the LRI for every single patient. It saves time. So again, much less time than femtosecond laser AKs. It's probably the same time or maybe even less than placing a toric IOL. Sometimes you know that it may be difficult to exactly rotate the lens. And even in the best of hands, it takes a few seconds to do placing the toric IOL. Whereas with the limbal relaxing incision, it's pretty easy to do it. It really saves time. I talked about you can buy the instruments, or you can use the disposable LRI packs that are made by Precision Lens, or even other companies that are out there. So I want to show you an unedited video here. So this is right before cataract surgery. This is a patient. We're just making a single limbal relaxing incision right before cataract surgery, just making ink marks here. And again, I purposely did not edit this because I wanted to show that in real time, this whole thing can be done relatively quickly. So again, fixating the eye, taking the LRI blade, and kind of, dimpling into the cornea and just kind of following the peripheral curvature of the cornea. It's really important to almost kind of twirl the finger. That's why I usually tell our trainees, it's almost like you imagine you're twirling, and then giving a little bit of heme like that is okay. It means you're exactly at the limbus, and then that's it, and you're ready to proceed with surgery. So that whole thing took maybe a minute, maybe even less than that. But I purposely wanted to show an unedited video to kind of show you in real time how much time that actually takes to do. I also wanted to show you here, I apologize, I couldn't get this video into the presentation. So for a second, I'm going to stop this share. I have it pulled up in another screen right next to me. So I'll go straight to the video. And this is a patient here in this video. I hope that video is coming through, that we did a scleral fixated lens. So this is a Yamani. You can see the pars plana infusion is still in here. And at the end of the case, the patient had some astigmatism, so we wanted to make an LRI. I just wanted to show you how quickly that can actually happen. So we're just making the ink marks, and then we're going to do 2 paired LRIs. So again, infusion is on. So posterior infusion is on. Here we have a Yamani lens, a scleral fixated lens. You can see the haptic is over here and over here. And again, unedited to show you the amount of time it's going to take to do these. So just using the diamond blade and fixating the eye, just following the curvature of the cornea at the limbus there, making sure we sort of stay within the surgical limbus until that mark there. So again, a little bit of heme there. Again, that's normal. And then we're going to make another incision here. I'm just kind of pointing this out, showing where we're going to do this. And again, fixating close to the area that we want to make the limbal relaxing incision. And we're going to make it right up to our main wound, which we use to place the 3-piece lens for the Yamani IOL. And that's it. So we've made paired incisions here in the steep meridian. And we're just showing here, we're just showing here that these are not, we haven't perforated. A little bit of heme there. The eye is still pressurized and formed, and we can continue there with the rest of the stuff there. So, okay, so I'll pause that, stop share there, and go back to my screen over here. I hope I did that transition successfully here. Okay, So successful. Experienced surgeons, some people have asked me, especially, practicing surgeons, oh, I haven't done these in a while, and, I'm not sure if I want to be able to do them. And I would say, experienced surgeons can achieve good correction of refractive and corneal astigmatism. And how do I know this? Is because, well, if resident surgeons can do it, you all can do them too. And I'm going to show you or summarize a paper that we did with resident surgeons, novice surgeons, and again, I think most of you all who are in practice, you're much better than our residents. And if they can do it, you can do it too. So again, when to use these limbal relaxing incisions. So cataract surgery with a monofocal IOL, certainly with lenses such as Eyhance, which give a little bit of increased depth of focus. Correcting that astigmatism would be very helpful. I mentioned a presbyopia correcting IOL with approximately 1 diopter astigmatism, for which a toric lens would not be helpful. IOL exchange. So just this morning, I did a patient with an unhappy diffractive optics trifocal IOL. I took that lens out and actually put an Eyhance in that patient. And the patient had about 1.25 diopter of astigmatism, and basically did 2 limbal relaxing incisions for that, centered at 90 degrees. And hopefully we'll have corrected some of that astigmatism. I showed you about the sclerofixated lens surgery. Another example, which may come up from time to time, would be to supplement toric IOL correction. Every now and then, we may have a patient who does have regular corneal astigmatism, let's say about 5.5 diopters. We know that even the highest toric lenses available in the United States can adequately correct about 4.5 diopters at the spectacle plane, at the corneal plane. And so therefore you're like, oh, wait a minute, I can only correct 4.5. This patient has 5.5. That would be a great example of using the toric IOL, but then still doing a limbal relaxing incision to correct the residual astigmatism that is there. Other cases of low amounts of astigmatism, such as post-penetrating keratoplasty, or let's say there's a patient who's post-cataract surgery. These can also be performed as a standalone procedure, even in the office or a minor procedure room, or if it really happened, you could go to the operating room for that. What are some limitations? Well, certainly we know that the biggest limitation of limbal relaxing incisions is that they really reduce astigmatism. They don't fully correct all of the astigmatism. So there's about 50% under correction, I think, should be expected in the LRI incisions that we're going to make. We may flip the corneal astigmatism steep meridian. It's very rare because this implies overcorrection. In very rare circumstances, it may induce irregular astigmatism. This is rare with LRIs because where we're placing these LRIs is in the circumlimbal cornea. The biomechanical structure of the cornea is very different compared to the mid-peripheral cornea. So this is an area where it's much more amenable at this annulus, at the circumlimbal area, where you can make incisions and not really induce a whole lot of astigmatism. Plus, you're further away from the corneal center, so we're really not inducing a lot of irregular astigmatism. The mid-peripheral cornea, which historically where we made astigmatic keratotomies, which were used for correcting high amounts of astigmatism after penetrating keratoplasty, it's kind of like, why the heck are we going back to the mid-peripheral cornea with femtosecond laser AKs? It's like going back to flip phones when we kind of realized with AKs, manual AKs, that's not a good area of the cornea. The mid-peripheral cornea is kind of like the Bermuda Triangle. You want to stay away from there because you don't know how thick the cornea is, and the higher chances of creating problems, including irregular astigmatism, in that area. So I think a safer area of the cornea to kind of make incisions is really the circumlimbal cornea, which is where the limbal relaxing incisions are made. This is a paper that we did, which reported resident performed LRIs in 118 eyes, and we actually measured both the refractive and the post-operative keratometric astigmatism. And basically what we found for at least 1 year at 1 month, 3 months, and 12 months, that the resident performed LRIs was very successful, that there was reduced astigmatism in all of these eyes at all of these different time points. There was some regression, but it was really about 0.11 diopters, which is not even a quarter diopter of regression. So in other words, residents did a pretty gosh darn good job at correcting astigmatism. So certainly experienced surgeons can do a much better job. Again, kind of a busy slide with a lot of tables and a lot of numbers here, but really I wanted to show this, that even in patients regardless of the amount of astigmatism, less than 1 diopters, 1 to 2, or even greater than 3, whether it was with the rule, against the rule, or oblique, really in all of these groups, residents were able to reduce corneal astigmatism regardless of the magnitude and the location of the steep meridian. So in other words, it was successful. The astigmatism improved regardless of the amount and the type, in other words, a steep meridian, and the residents did as well as experienced surgeon. The literature reported that there's about 25 to 50% reduction of refractive astigmatism for experienced surgeons, and our residents did about 43% of the astigmatism at 1 year, which is, I would say is quite successful because it's right in the middle of what experienced surgeons have reported. In the interest of fairness, I should say, safety-wise, there was one complication. There was a perforation that we found due to an adjustable diamond LRI blade where the safety guard had broken, and I ended up having to take over that case and suture it closed. And the patient ended up doing fine, but as you can see by that manifest, there certainly was a lot of astigmatism left over. But these are things which can happen, and that's why I don't recommend the adjustable blades, because if the processing facility or the central processing doesn't do a good job, and this is again at an academic institution, so it's in a hospital-based setting, they're not going to take care of those blades as much as a dedicated eye surgery facility or even many of the ambulatory ASCs. Supplementary income, that's the other S there. Again, I talked about decreasing reimbursement. Not all patients may qualify or can afford premium IOLs, including toric IOLs. And so this is something to think about where you can charge patients for LRIs performed in these various surgeries. So conclusions here and some of the take-home points. Many patients have low to moderate amounts of corneal astigmatism. I would argue that the manual LRIs are an excellent option for many patients, especially if finances don't allow them to pay for a toric IOL, and especially if you want to still deliver some good outcomes for some of these patients. And I found in my practice over the years that sometimes these patients where you do just regular good cataract surgery, they end up referring their friends and neighbors and family, and they actually do qualify for torics and presbyopia correcting lenses. And so in some ways, it's a good business building model to do astigmatism correction, even if we're just barely breaking even with some of the reimbursement or whatever it might be. The 5 S's, as I talked about, manual LRIs are simple, they save time, they're successful, they're safe for the patient, and they can help supplement the income. And finally, I think in modern cataract surgery, it's really time to revisit an old friend, which is LRIs, and consider using them in our patients, especially when we're using some of our newer IOLs, such as the iHance and other lenses that really correcting the astigmatism unleashes the full power of the lens. That's my presentation. So those are my 3 kids, LRI. No, I'm kidding. It's Rabia, Nabil, and Zainab. So only one has the same letter as the R of LRI, but those are my kids. So any questions, or I'm going to just turn it over to, yeah, so I'll just say what I'll give an estimate here. Talking to places and talking to surgeons around the country, most people are charging anywhere from $350 to $500 for the LRI. I think that's kind of what I've seen across the board. And I would say that our fee is on the lower end of that scale. I guess technically you could charge as much as you want for these, but so I think you have to kind of maybe talk to your individual facility and kind of see what kind of price point makes sense. So, but I think that's kind of the sort of that $300 to $500 price range. And again, I would say at our facility, we're closer to that lower end of that scale. So probably leaving some money on the table, but I feel it's not as predictable and guaranteed as a toric IOL, but nonetheless, it does reduce astigmatism. And I think it makes for a better patient. And certainly I pretty much use the iHance, for example, for most of my monofocal cases. And I think we've been tracking the intermediate and near vision outcomes. It certainly has helped with that. Do I do these in the office ever? I would say extremely rarely, because I mostly do them with cataract surgery. And most of the times, if somebody comes in with pseudophakic corneal astigmatism, that's usually very minimal, and most patients don't want to do another surgery, or if they usually have some significant refractive error as well. So those patients may be better off candidate for laser vision correction. The one exception to that would be somebody who, let's say they're minus 75 plus 150 times 90 after cataract surgery. In other words, their spherical equivalent is plano, and the keratometric astigmatism shows there's a diopter and a half at 90. I may consider doing that. But I would say, at least in my practice, very rarely, but I know there are many surgeons out there that do them very frequently. Does the patient pay for topography, or is it covered? It's a great question. So in my practice, which is a cornea heavy practice, many patients have corneal disease, and so we're able to justify corneal topography under that. But if somebody doesn't have corneal disease and it's just regular astigmatism, because I'm in an academic institution, I kind of get away with basically not charging the patient for the topography. At least no one's told me yet not to do that. But no, I don't charge them for that. I started my life out in private practice, and so I do sympathize. I understand the nuances that are there with that. I do know that some surgeons who do LRIs or toric IOLs, they include topography sort of as their ABN part of their refractive package, so that the patient they're paying for like a toric IOL, a certain amount of fee out of pocket, and that includes the topography for that. So, and explaining LRIs to patients. Yeah, I basically tell them this, I basically tell them that, Mr. Jones, Mrs. Smith, you have a diopter and quarter of astigmatism. A toric lens would be a great option, or even if they have more than that, I tell them, toric lens would be a great option, but you either don't have enough astigmatism for a toric lens, or if somebody says, well, I can't pay, the fee for a toric lens, then I'll bring them up and, well, here's another option that we could use to at least reduce the astigmatism. It's not going to be as effective as a toric lens, but certainly having 2 diopters of astigmatism is worse than having 1 diopter that we can at least reduce with, as we said, you can expect to favorably correct about half or a little bit more than half of that. So I certainly think, leaving them at least with 1 diopter of astigmatism is better than leaving them with 2. And that's why, if they have a diopter and a half, you can feel pretty comfortable. You'll be able to reduce that down to about a half a diopter afterwards. So that would sort of be my way I would kind of go about doing that, is really just offering it to patients who are not good toric candidates or who may not be able to afford the toric lens. How many leaks have I seen at day 1? Other than the perforation that I mentioned in our resident cases, which was due to a malfunctioning blade, I mean, knock on wood, in over 10 years, I've not seen any leak or perforation that has happened other than that one case. And again, that was due to one of those ones where you can fix it every 10 microns or really however you want to do it. I really like that one they showed where you can maybe do 0.5, 0.55, and 0.6. You only have 3 options. But the ones where you can kind of dial in and click really up to, however many microns, those I think, those are harder to control. I primarily used a fixed depth 600 micron, and so I don't think it really, I've not seen any leaks, at least, like I said, but I have seen that one perforation, and I want to be fair and fully transparent that did happen with a resident case. Does your para-incision get in the way sometimes? Great question. And the answer to that would be no. You can actually make your para behind the limbal relaxing incision, or even slightly in front of it, and it really doesn't mess it up. But I wouldn't go straight. I wouldn't make the limbal relaxing incision and then go through the limbal relaxing incision with your para. So you can either just go right underneath it, so a little bit more closer to the limbus, or almost kind of like a limboscleral for the para. But that can happen, especially if it's oblique astigmatism that we're trying to correct there as well too. So. Does he have a minimum or maximal corneal astigmatism that I'll perform an LRI? Great question. So the minimal astigmatism, I would say, really would be a diopter or more. I take that back, about 0.8 diopters or more, especially if it's against the rule. If they're with the rule, I may leave them alone because, pseudophakic with the rule astigmatism does confer some benefit. But so I definitely would recommend aggressively correcting against the rule. So think A for aggressive, A for against the rule. So you want to try to correct against the rule, even if it's like 0.75, 0.8 diopters. But by and large, I think if I have a diopter or more, I definitely would want to do a limbal relaxing incision. As far as the max, as I showed you in the Riaz nomogram, which again, I don't endorse, is just a summary of everything else that's out there. You can correct up to 3 diopters with a limbal relaxing incision. As I showed you in the resident paper, there were some patients who had 3 diopters or more and got limbal relaxing incisions. Again, if finances allow and circumstances allow, I certainly think a toric IOL would be still the best option for patients with up to 3 diopters or even more than 2 diopters. But we all know that some patients can't afford that. So I'd much rather do a limbal relaxing incision for someone with 3 and explain to them that, hey, Mr. Jones, we're just going to try to reduce as much as we possibly can. You're still probably going to need glasses, but at least your glasses aren't going to be as cumbersome and bulky because we would have reduced some of that astigmatism. And I think patients understand and appreciate that. And especially for like a $300, $400 price point, I think it makes it much more palatable for pretty much most patients to be able to afford that as compared to the prices with a toric lens or a presbyopia correcting lens, which we all know, not everybody can afford unless you practice in a very wealthy area. And I don't. I'm an academic institution, and we do have some wealthy patients that come in, but by and large, they're not very wealthy patients. I've literally given patients multiple times $20 out of my pocket to go buy prednisolone because their corneal transplant is failing. So I see a lot of patients dissatisfied with about 0.7 to 1 diopter in the PC IOLs. Would you do an LRI on these non-toric IOLs? I'm assuming if the patient is already pseudophakic. I definitely think if the patient has a presbyopia correcting lens, like a diffractive, like a multifocal, trifocal, extended depth of focus. I'm trying my best not to mention any names as much as possible. But if they have, or even if they, so I definitely would do the LRI in those patients, pseudophakic, especially if they're unhappy, and the spherical equivalent of that ends up being 0. But as I mentioned, in the extended monofocal lens, that's a lens which I very much like. And in those patients, I'm much more, I want to correct the astigmatism as much as possible. And even if patients sometimes can't afford that, what I do then in that case, and again, I can do that because I'm in academics, I can have the resident or the fellow do the LRI and not charge the patient because they're doing it, and at least deliver that. But in those patients, again, if those financing can allow for it, I still want to do it because I think it delivers a better refractive outcome, both uncorrected vision wise, but even corrected vision wise, they don't have to, wear as much cylinder in their glasses. If I can keep them, half a diopter or less, or even 0.75 less, because we've taken their diopter and a quarter and at least brought it down to a half a diopter or even 0.75, that still, I think, leads to a better amount of, patient satisfaction. And we're actually looking at our eye-hands outcomes, for example, as I mentioned, with their distance, intermediate, and near uncorrected, and actually stratifying those patients with the amount of residual astigmatism. And those patients that are consistently getting 20, 20, 20, 25 at distance, but then also getting that 20, 30 intermediate and 20, 40, 20, 50 up close, those are the patients that by and large have 0.75 or less of refractive astigmatism. So I think those surgeons who are interested in using that type of a lens, or even, I do a lot of, to be fair, I do in patients, especially before I used to do a lot of the zero aberration and Vista lens, and even correcting the astigmatism in those patients, I think leads to better outcomes. So I think by and large, this is something which I think all surgeons who even putting in monofocal IOLs don't want to mess around with, all the fancy pants lenses out there. I still think that the limb relaxing incision for low amounts of astigmatism can be a very, very successful and thing for you and your patients. And I would urge you to think about it.